everyone, this is our PHD225 group assignment video, and this is all our group members. In this video, we will take a look at the comparison between ACARBOSE and glibenclamide in the terms of general description, drug classification, mechanism of action, therapeutic indication, clinical characteristic, summary on pharmacokinetics, and we will also take a look at the dosage and administration, contraindication and precaution, potential side effects and management, interaction between the drugs and duration of therapy. Without further ado, let's start. For general description of ACARBOSE, it is a drug that used to treat type 2 diabetes mellitus. When a patient is suffering from type 2 diabetes mellitus, insulin that is secreted by the pancreas is not sufficient. This can cause high blood glucose level in body. ACARBOSE can lower the blood glucose level by preventing the breakdown of starch into glucose.
So the next drug we are going to discuss today is glibenclamide. It is also known as glyburide in some countries. It is used as adjunct to diet to lower the blood glucose in patients with type 2 diabetes. It is also typically given to patients who cannot be managed with the standard first-line therapy such as metformin. Glibenclamide works by lowering blood glucose concentration by stimulating the secretion of insulin from the pancreatic beta cells.
Next, we move on to the drug classification of ACARBOSE. It belongs to the alpha-glucosidase inhibitors.
On the other hand, glibenclamide is a second-generation sulfonylurea anti-diabetic agent.
Mechanism of action of ACARBOSE. It competitively and reversibly inhibits membrane-bound intestinal alpha-glucosidase and pancreatic alpha-amylase. So, this will result in delayed absorption of glucose and degradation of intestinal complex carbohydrates and disaccharide in the small intestine. Thus, it will reduce the postprandial rise in blood glucose level.
So next, how does glibenclamide works? So first, high concentrations of ATP due to the high intake glucose that needs to be metabolized causes inhibitions at ATP-sensitive potassium channel at beta cells, which means glibenclamide block inflow of potassium ions. This will cause depolarizations of the cell membrane and trigger activations of voltage-gated calcium channel and thus cause influx of ion calcium. So high concentrations of ion calciums mediates the release of insulin-containing granules into the bloodstream.
Next, we will talk about the therapeutic indication for ACARBOSE. It is for type 2 diabetes mellitus in patients inadequately controlled on diet alone or on diet and oral hypoglycemic agent.
Therapeutic indications and clinical use for glibenclamide also similar to ACARBOSE, which it is for type 2 diabetes mellitus in patients with inadequate glycemic control on diet and exercise alone.
Next, we move on to the clinical characteristic of ACARBOSE. It is suitable for overweight or obese patients because no weight changes associated with ACARBOSE therapy. Secondly, it is safely used for elderly patients because control blood glucose levels. Thirdly, patients with postprandial hyperglycemia due to reduced 2-hour post-meal glucose peaks. And lastly, it is not for patients with moderate to severe renal impairment as it can increase in proportion to the severity of renal impairment.
On the other hand, glibenclamide is suitable for type 2 diabetes patient who is non-obese, deal with postprandial hypoglycemia, who is with adequate renal function because glibenclamide reduces clearance and active metabolites, and also for patients who is without liver impairment since glibenclamide is metabolized by the liver.
Next is the summary on pharmacokinetics of ACARBOSE. For absorption, ACARBOSE works locally in the gastrointestinal tract and has minimal systemic bioavailability that is less than 2% is absorbed as the active medication and 35% as metabolites. For metabolism, ACARBOSE is metabolized in the GI tract by intestinal bacteria and digestive enzyme. Lastly, for the excretion, the kidney will filter the absorbed drug and 51% of oral dose gets eliminated in feces.
Next, the summary of pharmacokinetics for glibenclamide is first we go to the absorptions. Glibenclamide have rapid and complete oral absorptions, typically 90 to 100%, with peak plasma levels reached in 1 to 4 hours. Next, for the distributions, glibenclamide is 99.9% bound to protein in plasma, with more than 98% accounted for by binding to serum albumin. For the metabolism, glibenclamide is extensively metabolized in the liver. Next, for excretions, elderly patients excrete 4 to 13 hours, meanwhile younger patients excrete 4 to 14 hours. Excretion is approximately 50% renal and 50% biliary, with both parent drug and metabolites eliminated.
Let's continue with patient counseling points. First, for doses and administration for ACARBOSE, it is administered orally by mouth and to be chewed with first mouthful of food or swallowed whole with water immediately before food. And the dosage range is 50 to 100 mg 3 times a day. Next, for glibenclamide, it is administered orally by mouth and should be taken with food. And the dosage is 2.5 until 5 mg daily and the maximum is 20 mg daily. Next, for duration of therapy, for ACARBOSE, it is for a long term and take as prescribed by doctor. And this is the same goes for glibenclamide for long-term treatment and take as prescribed by doctor. Next, we continue with the potential side effect and management. The potential side effect of ACARBOSE are diarrhea, flatulence, abdominal pain, nausea and vomiting. The management are: first, take ACARBOSE with insulin or sulfonylureas can increase hypoglycemia, so advise patient to carry glucose, not sucrose or table sugar. The second management is experiencing flatulence or diarrhea, so the pharmacist need to advise the patient to not drink or have meals containing carbohydrates for the next 4 to 6 hours. And the third management is patient education. Stress the importance of chewing or swallow whole with first mouthful of food to exert its therapeutic effects. Next, we continue with potential side effect of glibenclamide. The potential side effects are hypoglycemia, weight gain, gastrointestinal upset, allergic skin rashes, nausea, diarrhea, and vomiting. The management is treat hypoglycemia with 15-15 rules. First, the patient needs to check and record the blood glucose level. If less than 3.9 millimole per liter, the patient needs to take 50 grams of carbohydrates. The 15 grams of carbohydrate choices is 120 ml of fruit juice, half tin of Coke, 7 or 8 soft candy, and 1 teaspoon of sugar diluted in water. Next, the patient needs to wait for 15 minutes after taking the 50 grams of carbohydrates and recheck the blood glucose level. And finally, repeat the process if needed until blood glucose level of the patient is more than 4 millimole per liter. We continue with contraindication and precaution of ACARBOSE and glibenclamide. The contraindication of ACARBOSE are disorder of digestion or absorption, hernia, inflammatory bowel disease, hepatic impairment, and predisposition to intestinal obstruction. Next, the precaution of ACARBOSE are: first, ACARBOSE may enhance hypoglycemic effect of insulin or sulfonylureas. The second one, patients with hepatic and renal impairment should avoid this medication. And lastly, pregnant and breastfeeding women should avoid taking ACARBOSE. We continue with glibenclamide. The contraindications are patients with type 1 diabetes mellitus, contraindicated in patients that are allergic to sulfur, and the third one is presence of ketoacidosis. The precaution of glibenclamide are use in caution for patients with hepatic or kidney impairment. The second one is do not skip meals while taking glibenclamide. Third one is avoid alcohol as it can cause hypoglycemia. And lastly, patients with G6PD deficiency should have precaution when taking glibenclamide. Let's move on to the interaction drug with drugs and drug with foods for ACARBOSE and glibenclamide. For ACARBOSE, interaction drug with drugs, the first one is ACARBOSE decrease the concentration of digoxins. Next, pancreatine decrease effect of ACARBOSE. Fenfluramine also with ACARBOSE cause decrease of blood glucose concentration. And finally, ACARBOSE with insulin or sulfonylureas cause risk of hypoglycemia. For ACARBOSE interaction with food, an increased intake of sucrose during treatment cause flatulence, bloating, and diarrhea. Next, for interaction drug with drug for glibenclamide, the first one, bulevirtide, increased exposure to glibenclamide. The second one, bosentan, increased risk of hepatotoxicity when given with glibenclamide. And lastly, NSAID, ACE inhibitor, and dafibrozils increase hypoglycemia effects. And interaction of glibenclamide with food, such as alcohol, increased risk of hypoglycemia. Lastly, drug storage and handling for ACARBOSE, store below 25 Celsius, protect from light and moisture, keep away from children, store in a cool and dry place, and must not be used past the expiry date. And the same goes for glibenclamide. In conclusion, both ACARBOSE and glibenclamide are used in treatment of type 2 diabetes mellitus. that vary significantly in terms of their mechanism of action, clinical uses, and safety profile. Glibenclamide, a sulfonylurea, stimulates pancreatic insulin secretion and effectively lower blood glucose concentration, but it carries a high risk of hypoglycemia and weight gain, which means that it is less suitable for obese patients. In contrast, ACARBOSE, an alpha-glucosidase inhibitor, delay glucose absorption in the intestine and primarily targeting postprandial hyperglycemia, and it commonly causes gastrointestinal side effects such as flatulence and bloating. Our recommendations are: glibenclamide is more potent and suited for non-obese patients that deal with postprandial hyperglycemia and have a regular meal patterns. ACARBOSE is preferable in obese individuals or those patients who need to prevent hypoglycemia. Nevertheless, a therapy should be individualized based on the patient glucose profile, comorbidities, and tolerance to side effects, and most importantly, a careful patient counseling on side effect management and adherence in taking the medication.
To succeed this group assignment, everyone participates by attending the face-to-face discussions about the group assignment's details rubric. And also after the group discussions, we divide the tasks equally for everyone and also look for the templates to be used. Lastly, during our mid-semester holiday, we conducted a voice call for some clarifications for some parts that we are unsure.